So this is the recording for part B of chapter 19. Last time we did the atrioventricular valves. There's another type of valves called semilunar valves. The semilunar valves also prevent blood from returning, going backwards. This is going to prevent blood from going into a ventricle. They're different than the atrioventricular valves because they only have the cusps. They only have 3 cusps. So the bicuspid is the only one that has 2. Between the right ventricle and the pulmonary trunk, you have the pulmonary valve. And between the aorta and the left ventricle, you have the aortic valve. So, superior view. With the 2 atrioventricular valves, they were right and left across from each other, here and here. With the pulmonary and the aortic valve, they're anterior and posterior. So the anterior most is the pulmonary valve. This is a superior view. This is another view of the pulmonary valve leading to the pulmonary trunk. So it's named for the large artery that the blood is supposed to go into. The aortic valve is not something you can really see in this picture here on the right. You can see a little bit of it right here. You have a better view of it in this superior view right here. So this is the closed side of the valve, not the open side or the incoming side. Now, you'll also see these called aortic semilunar valve and pulmonary semilunar valve. But I don't usually repeat the word semilunar. Now, this is also a good picture because it shows how the coronary arteries come off of the aorta right after the aortic valve. This would be the left coronary artery, and this would be the right coronary artery. And so the openings are right after the valve. So semilunar valves, again, work by pressure. When the pressure is high in the ventricle, the valve opens. When the pressure drops, then it's going to close. Okay. Coronary circuit is a specific segment of the systemic circuit. So it's a subdivision of the systemic circuit. It carries blood directly to the wall of the heart from the aorta. Here's the left coronary artery and the right coronary artery, and then they have lots and lots of branches. You see them here. They latexed the blood vessels, latexed the blood, and then they got rid of the tissues. The Coronary arteries are going to branch, and then they all empty into cardiac veins, which are going to converge and empty into this coronary sinus. It's a sinus because it's a wide oval tube rather than a round round tube. It's flattened, and it has its own specific opening into the right atrium. So you have three things that go into the right atrium: the superior vena cava, the inferior vena cava, and this coronary sinus. For some reason they called coronary vein or coronary arteries, and then it's cardiac veins. Okay, so with the coronary circuit, these are the blood vessels that get blocked, and you would have to have the coronary bypass or a stent placed in. So the stent is like a little piece of a straw, and they can insert it either through a blood vessel in the wrist, the radial vein, or in the femoral vein, which is down in the groin. And so they snake a catheter through the blood vessels and into the heart, and then it goes into the coronary vessels. Bypass means, say, if there's a blockage here, they go in and take a piece of the femoral vein, and they put a tube and they override it. They go around the blockage. So they splice in a piece of another blood vessel. Typically, it's the femoral vein. With veins, they're going to develop where you need them. So you will get a new set of vessels that drain blood from the leg when they take out the femoral vein. Currently, they can do up to 10 bypasses, but at one time, they typically only do 5. So coronary circuit. You have the left and the right coronary arteries, and then there's a branch off of the left coronary artery, because the left coronary artery proper comes down here. And it becomes the circumflex artery, which comes around. And then you have a great cardiac vein and a middle cardiac vein and various other ones, but they all empty into that coronary sinus, which empties directly into the right atrium. Cardiac muscle tissue has cardiac muscle fibers, which are also called cardiomyocytes. Oops. So cardiomyocytes, heart muscle cells. They're short, branched, and striated. And part of this is review from the tissues, and part of this is new. They each have one nucleus per fiber, which we see here. You have intercalated discs, which anchor the cells apart. So when this cell contracts, it doesn't separate from this cell or this cell. They are able to generate and distribute their own electrical impulses, which we call being myogenic. The muscle generates its own impulse. So even without nerves attached, the cardiac muscle tissue can contract and relax. Now, the contractions are rhythmic, so the entire chamber works as a unit. So the right atrium works as a unit. It contracts and relaxes at the same, all the tissue. The left ventricle contracts and relaxes. The right ventricle contracts and relaxes as a unit. The left ventricle contracts as a unit. If you have a petri dish and can isolate a single cardiac fiber, it will have its own contraction and relaxation rhythm. If you have a second one, as long as they're not touching, they're each going to have their own rhythm. Once they touch each other, they adopt the same rhythm. So they work together as a unit. Myogenic. So unlike skeletal muscle tissues, where you absolutely have to have nerves attached to cause them to contract and to relax, you don't have to have nerves attached for the cardiac muscle. This is also an attribute of visceral or smooth muscle tissue. Because of this myogenic trait, some of the tissue is specialized just to do the production and distribution of the electrical current. And so that's where we have the cardiac conduction system. You have cardiomyocytes or cardiac muscle fibers that generate and distribute the impulses to cause contraction and relaxation of the heart. So their job is to act more like nerves than muscle tissue. Physically, when you cut into the heart, you can't see the difference. You have to have a way of watching the electrical activity to see that. Now, the cardiac conduction cannot make adjustments if you need to change the heart rate because of what's going on in the body. And so that's why, yes, we do have nerves attached to the heart so that we can either increase or decrease heart rate because of what's going on in the body. So cardiac conduction system. The cardiomyocytes or cardiac muscle fibers, whose job it is to generate and distribute the impulses. It's not there to contract and relax. Okay, components of the cardiac conduction system. And here's one of the videos that you need to watch because we can't watch it here in the PowerPoint. But it goes through the cardiac conduction system. So the sinoatrial node is this small area here. Sinoatrial node is located in the superior dorsal wall of the right atrium. It spontaneously generates impulses to cause both atria to contract. So the whole chamber acts as a unit, and now we're showing that both atria contract and relax at the same time. Both atria contract and relax at the same time. So the sinoatrial node is going to broadcast impulses, kind of like a radio station broadcasts music and other audio material. It does this on a regular basis. The sinoatrial node can sometimes not work, and that's where someone would have to have a pacemaker put in place. The pacemaker can either completely replace the sinoatrial node, or it can help the sinoatrial node, meaning that there's a sensor. If there's no electrical activity within a certain amount of time, then the pacemaker, the artificial pacemaker, is going to send out an impulse. If it does send out an impulse, then it doesn't, the artificial pacemaker doesn't. So it's a backup. Some of the pacemakers have a defibrillator setting. Some of them don't. The original pacemakers were something that could be monitored over the telephone lines. Back before, I know you're going to go into shock, but back before we had the internet, pacemakers were something we could check over the phone line, so they didn't have to drive all the way to the hospital. Okay. That gets us the atria working. Now, with the ventricles, you have several structures. So you have the atrioventricular node, which is here. That's another bundle located in the medial wall of the right atrium. It spontaneously generates impulses that go to the atrioventricular bundle. Now, they're using yellow because it has a nervous function of excitability. This is going to lead eventually to the contraction of ventricles. With ventricles, they have to begin their contraction at the apex, and then it has to migrate upward, because when ventricles contract, they have to push the blood up. The third component in the cardiac conduction system is the atrioventricular bundle. It's a narrow column of tissue that's going to carry, so by excitability, carry the impulse from the atrioventricular node over to the interventricular septum. It passes the impulse off to the two bundle branches. So the two bundle branches are going to conduct impulses along the interventricular septum to the Purkinje fibers. The Purkinje fibers are going to be embedded in the myocardium of the ventricles. They are going to in turn pass the impulse over to the myocardium. Again, that way the impulse and the contraction can start at the apex and go up, which is where the blood has to go. So 5 components of the cardiac conduction system. Sinoatrial node for both atria to contract, atrioventricular node, atrioventricular bundle, the bundle branches, and the Purkinje fibers, so that the ventricles can contract. Okay, so we have depolarization and repolarization. This should be a review from the nervous system. Part of the action potential is called depolarization, and that's when sodium is flowing, out. Sorry. Sodium is flowing out of the cell. That's going to trigger systole, which is contraction of the heart muscle. We need to go back and define systole and diastole. Systole is contraction of the heart muscle tissue. It generates a pressure called systolic pressure. The systole itself doesn't move blood, it's the pressure that's built up. So you have systole, and that builds up the pressure, and then that's what moves the blood. And systolic pressure, the force exerted during the contraction of a heart chamber. Diastole refers to relaxation of the chamber of the heart. Diastolic pressure is the force exerted during the relaxation of the chamber of the heart. Now, what we see happening is like what happens in a bulb syringe, most often associated with removing snot from, or mucus from, little guys' noses. So when you squish the bulb syringe, that would be systolic pressure, systole and systolic pressure. When you allow that to fill back up, sucking is created, and that's the diastolic pressure and diastole. When you remove mucus, you want to push the air out and then stick it in the nose and allow that force to suck the mucus out. And then you squish the bulb syringe again to push the mucus out. Okay, so depolarization and repolarization. Part of the action potential. Sodium flows out of the cell, which triggers systole or contraction. Repolarization is the part of the action potential when potassium flows out of the cell. And so that's going to trigger diastole. Okay, so here you can see sodium going in, potassium coming out for the action potential. This is a measurement of those in the heart tissue. So the electrocardiogram is a recording of the electrical activity in the heart tissue. The electrocardiograph is the machine that does this. Now you have to go through a certain training and certification program to be able to record these and to be able to read them. The volume of tissue on the heart means that we can put sensors on the skin and record these electrical changes. So one complete heartbeat or one cardiac cycle is recorded and then another, and another, and another. So one complete heartbeat. The electrocardiogram has three parts. The P wave, oops, is a recording of the atrial depolarization, and that will trigger the atrial systole. Then you have the QRS complex, which is all of this, and that measures two things: atrial repolarization and ventricular depolarization. So the one you're going to see most is the ventricular depolarization. Lastly, you have the T wave that measures ventricular repolarization. So all three of these equal one complete heartbeat. The interval between cardiac cycles or heartbeats is about 0.8 seconds. When you look at electrocardiograms, you have time and you have electrical current. So it's a graph. Here we see matching up of the depolarization and repolarization and matching that with the electrocardiogram. So depolarization of the atria is the red. That's what we record as the P wave. Repolarization is green. Notice it's in the ventricles. The depolarization is going to start at the apex and move up for the QRS complex. And then T wave, again, starting at the apex and going up for the T wave repolarization. So there we're matching the parts of the heart with the electrocardiogram. Now, if this doesn't happen like it's supposed to, we call it an arrhythmia. With the arrhythmias, you have an irregular heartbeat. It either means that the rate is off, too fast, too slow, or you have abnormal electrical events. There are four categories of arrhythmias. We're only going to define two of them right now. The other two are discussed deeper in the chapter. So you have the terms flutter and fibrillation. This is what a normal sinus rhythm looks like. Each of the cardiac events are the same, and they are happening at intervals which are acceptable in distance. A flutter is an arrhythmia where you have an abnormal electrical events that are repeated. Abnormal electrical events that are repeated. So there's a pattern. Here we can see there's no QRS complex and there's no T wave. and it'll go back to being that way. That would be a flutter. Here, there's no P wave. So the sinoatrial node is not working. They need a pacemaker. So it's this problem, but it's the same problem each time. Here, this heart block means that the atrioventricular node isn't working like it should. A lot of times you'll see like 2 abnormals, and then you'll see like 3 or 4 normals, and then you'll see 2 more abnormals. And so that's a different kind of pattern. With fibrillation, that's what we see here. You see rapid, uncoordinated electrical activity in the heart. Rapid, uncoordinated electrical activity is fibrillation. There are 2 kinds of fibrillations. Atrial fibrillation, which is not what we see here. That's when the atria are basically in a spasm. A lot of times this can be caused by trauma. If someone's in a concussive event, like an explosion or in a car accident where they stop really suddenly, that can damage the heart long term. Atrial fibrillation can be caused by other things, medications, chemicals. Atrial fibrillation is not always considered life-threatening because it can usually be treated with medication, or it can be treated with an artificial pacemaker. What we see down here is ventricular fibrillation, rapid uncontrolled electrical events where the ventricles are basically in a spasm. They're not moving any blood. So this is life-threatening. And this is why they invented the defibrillator, which applies electrical stimulus to the heart from the outside. So arrhythmias, 2 of the kinds, have to do with the abnormal electrical events, flutters and fibrillation. And so that's the end of part B on chapter 19.